Thank you very much for having me testify today. Representative Chairman Marin, Vice Chair Manning, Ranking Member Boyd, and members of the Health Committee. It's my pleasure to testify before you today in regard to House Bill 177. This legislation seeks to remove an unnecessary regulatory burden that acts as an impediment to APRN practice. House Bill 177 will reduce bureaucratic hoops and increase access to care by eliminating mandatory collaborative contracts between physicians and certified nurse practitioners, certified nurse midwives, and clinical nurse specialists. With the trend of larger hospital systems buying physician practices, it is becoming increasingly difficult for APRNs to find physicians to collaborate with. This means physicians who were once able to be collaborators in the community with any APRN can now only be collaborators for the system and with APRNs also employed by that system. This drastically limits providers in certain areas. Today, more than 1.4 million Ohioans lack necessary access to vital primary care services, as well as other services like mental and behavioral health. In fact, the federal government has designated 159 and growing healthcare provider shortages areas across the state. This means that just 55% of patient need is met. According to U.S. News and World Report Best States ranking, Ohio is 36th in healthcare. Anecdotally, 8 of the 10 top states for healthcare also do not require this contract. APRNs offer a high-quality, accessible, and affordable solution to the state's healthcare access problem. Ohio's current laws governing APRNs are outdated and interfere with an APRN's ability to provide needed health care, especially to vulnerable populations in medically underserved areas. HB 177 is not an expansion of APR and scope of practice. Instead, it eliminates barriers to access that cause delay in treatment and contribute to healthcare inefficiency. According to numerous studies from the Journal of American Medical Association, research points to APRNs having higher concentrations in rural areas. Additionally, even in urban areas, APRNs are more likely to work with indigent populations. One such journal study looks at data from 2010 to 2016 and shows a narrowing gap between primary care APRNs and physician workforce supply over time, particularly in low-income and rural areas. These areas have higher demand for primary care clinicians and larger disparities in access to care. The growing AP supply in these areas is offsetting low physician supply and thus may increase primary care capacity in underserved communities. It also indicates in rural health service area where 41.3 APRNs per 100,000 population, while the highest physician supply was in metropolitan health service areas with 68 physicians per 100,000 population. Under current collaborative contracts, which 28 states have safely removed, including our neighbors in Kentucky and West Virginia, direct supervision is not required of the physician, and in most cases, the physician is typically in another location, only available by electronic means. In many instances, APRNs have very little interaction with their collaborating physician. Instead, they are professionally collaborating with a multitude of other physicians and APRNs, depending on the needs of the patient. In some cases, a patient may need to see a physician, and others they may need to see an APRN with a specific specialty. APRNs would continue to professionally collaborate with other providers on a regular basis, just as physicians currently do when something is outside of their education and training. It is also said by our friends on the opposing side of the issue that APRNs just want to practice medicine. Again, I want to reiterate that this bill does not grant additional scope to APRNs. If the bill passed today, APRNs would enjoy no further scope beyond what is currently already spelled out for them in the revised code. In that same vein, APRNs are strictly regulated by the Board of Nursing, just as the Board of Medicine has oversight with physicians. The Ohio Board of Nursing is one of the most vigilant regulators in the country, and nothing in this bill would make that any different. Just as the Board of Medicine would strip the license of a physician practicing outside their scope, so too would the Board of Nursing for an APRN. All it takes is one complaint to either of these boards and an investigation is open. Bottom line is APRNs and physicians are professionals, and the people who choose to be bad actors will lose their license. Over the next 10 years, the United States will face a shortage of more than 90,000 physicians. As Ohioans are aging and increasingly access primary care and other health services, this shortfall will become more and more acute. APRNs are licensed professionals who have postgraduate degrees, master's or doctorate degrees. They are trained to diagnose illness, treat patients, order tests, prescribe medicines, including Schedule IIs, deliver babies, and/or administer anesthesia, and do this in both primary and specialty care settings. They are required to pass rigorous national certification board exams to demonstrate their expertise, knowledge, and competency. APRNs are trained and equipped to fill the void of the millions of citizens nationwide that are being added to the healthcare marketplace. Currently, 28 states plus Washington, D.C. have enacted legislation that gives patients direct access to APRN care and eliminate the requirement that APRNs enter into a contract with a physician to deliver care. It is my belief that this proposed legislation will help address in a safe way a significant access issue that utilizes highly trained APRNs. This legislation is one solution that will address the shortage of providers in Ohio in a drastic way. Thank you. I welcome